In a moment, you will hear Edwin Newman interview Dr. Theodore Cooper. From time to time during their discussion, you may wish to refer to the booklet that accompanies this audio cassette. To help you correlate the audio and visual parts of this presentation, I will break in at appropriate points to refer you to a relevant graph, chart, or table. When I do, you may wish to stop your cassette player to review the material. And now, the consequences of stress, the medical and social implications of prescribing tranquilizers. Outlook on a national program of education for physicians and consumers.
Hello, this is Edwin Newman in New York. With me today is Dr. Theodore Cooper, Dean of Cornell University Medical College and Provost for Medical Affairs of Cornell University. Dr. Cooper, the former United States Assistant Secretary of Health, is the executive editor of a new national education program for physicians and the public. The title of this program is The Consequences of Stress, the Medical and Social Implications of Prescribing Tranquilizers. A group of medical leaders will present this program, which is accredited for continuing medical education by Cornell University Medical College. Today we'll be discussing that program, the benefits of participation to you as a physician, and the objectives of that program to improve patient care. We will also discuss stress with its consequences as a major health problem in this country. Dr. Cooper, welcome.
Thank you.
Dr. Cooper, what I've been saying suggests that you have set out for yourself and for your colleagues a very formidable educational campaign.
Yes, it is.
Well, are we having a stress epidemic, or do you expect such an epidemic?
No, but we are concerned about the increasing pressures of life. I don't call that an epidemic. But more and more people are looking beyond themselves for help in coping with these pressures. And for that reason, it is essential that we examine as physicians and as a society the consequences of stress and its implications, both medical and social, of prescribing tranquilizers. We have known for some time that we have an educational problem. The recent report that an overwhelming percentage of all emergency room visits involving the use of psychotropic drugs also involves alcohol is important. That confirms the need for effective education on the use of tranquilizers in the treatment of stress. It also makes it pretty clear that education on stress and its management, to be effective, must include the consumer as well as the doctor and allied health professionals.
Well, I have to admit that I do not precisely understand the medical meaning of stress. Now, when I hear the word stress, I think of trouble or worry, or the feeling that the world is just too much for me or for somebody. But isn't that what life is all about?
Yes, stress is with us all the time. Most people can deal with stress most of the time. But all of us have some episodes in our lives in which we are inconvenienced or made ill by certain life pressures. It is the consequences of stress, the results of those feelings of trouble and pressure, that represent a health problem of enormous proportions in our society. For example, it's estimated that some of the consequences of stress are implicated in over 50% of all patient visits to physicians.
Yet the fact remains, Dr. Cooper, that some people seem to be able to take stress while others cannot. Take my business, the news business. Some of the calmest, most deliberate people I've ever known are in the wire services. You get them on the telephone, you're in a tremendous hurry, you ask a question, you get no answer. You think they didn't hear you, or you think that perhaps they consider your question so stupid that they're not going to answer it at all. So you ask another question, and then back comes the answer to your first question. What I'm saying is that the pressure of time or of the way other people behave seems to have no effect at all on these people. They're among the best and the fastest in the business. And one reason is that they stay so calm. But then you run into other people in news who shout, scream, they throw things, they swear. Now, I don't know which kind of reaction to stress is medically better for the individual, but it does seem clear that what is damaging to some people is not damaging to others. Well, after that long introduction, my question: is it possible to discuss stress or to define it in a way that applies to all people?
Yes, I think so. Our first task as an editorial board for this educational program was to define stress in practical terms. In our working definition, stress is the ordinary and extraordinary pressure of life that confronts every individual. Now, when that pressure exceeds the individual's ability to cope, it may signal the need to seek professional help.
Well, then is stress a medical problem, or could it be better described as an environmental problem?
Well, it's both, of course. It certainly is a problem that confronts physicians every day in their practices. As you described your colleagues in the business of reporting news, I thought of air traffic controllers and other kinds of special operatives who manage to function under pressure, but later report to their physicians with all kinds of complaints. For example, tension headaches, fatigue, inability to sleep, palpitations, musculoskeletal pain, choking sensations, indigestion, diarrhea, and I could go on. Or they just may report that they have problems in getting along in everyday life. Now, these are real medical problems, and physicians cannot ignore them because people look for professional help in order to keep on functioning in their everyday lives, whether this is relaying the news or bringing in giant airplanes for safe landing, caring for small children, keeping a family going with no frills and no money during an inflationary period, and so on.
Now, you said that stress is the ordinary and extraordinary pressure of life that confronts every individual. What happens when that pressure exceeds the individual's ability to cope?
Well, every person has a set of expectations and a set of facts about his or her own reality of life. Now, most times people can adjust or cope with the difference between expectation and reality. They make changes in the reality of life, or they make changes in their expectations.
Can you give an example of that?
Yes, let's say that the reality of Mr. John Doe's life fails to live up to his expectation. This gap creates a pressure for Mr. Doe. One way he can cope with that gap is to make changes in his life. Confront the person giving him a hard time, quit his job, get a divorce. Most often, however, he has to change his expectations. Now, this is ordinarily the time when a person goes to get advice from a physician. Now, another way that stress occurs is when reality outreaches expectations. For example, Mr. Doe may be promoted to a job he can't handle.
Is one set of circumstances more stressful for the individual than the other?
No. In either case, whether the reality outreaches expectations or vice versa, the individual will find he cannot cope with the resulting stress or pressure when the gap between reality and expectation grows too wide. Now, at that point, it's when most individuals turn to their physicians for help.
Well, most people like to think that they can handle their own problems, Dr. Cooper. I find it hard to understand droves of individuals going to their physicians saying that they can't handle their own lives.
Well, you're exactly right. Most people don't understand what is happening to them as that gap widens, and they're unable to adjust. They may begin to lose sleep, get knots in their stomach, develop aches and pains. They equate that to disease they have known in the past or that they've heard about. Now, in our society, it's generally more acceptable to have a physical rather than a psychological complaint. Besides, the individual usually only knows that he doesn't feel well.
Well, when people do go to their physicians in the circumstances you've described, what do they say?
Well, they come in complaining of fainting or feeling dizzy, tired, certain kinds of pains, palpitations, a whole raft of other possibilities, as I mentioned before. A patient is likely to say, "I can't sleep. Can you give me something for it?" He doesn't usually come in and say, "Why can't I sleep?" He rarely says, "I'm having trouble at work, and can you help me figure out what to do about it?" So the doctor has to be prepared to recognize a range of symptoms that represent manifestations of stress or its consequences, and be careful at the same time not to miss diagnosing an organic disease.
Is that differentiation difficult?
Not if the physician thinks of the possibility of a stress-related problem early on in the differential diagnosis. Now, the absence of physical findings in the initial examination and the positive indication of a manifestation of stress through the patient's history usually provide a positive diagnosis in the initial visit.
Well, then, is the usual treatment some kind of pill, or what you would call drug therapy? I would call a pill.
That depends on the patient. Of course, you try to provide some kind of counseling or insight, and if you can do that, the use of a tranquilizer may not be required. Many times, however, an in-depth discussion just isn't possible with patients who are undergoing very real and very painful stress reactions. Now, if the patient is overwhelmed with a consequence of stress, pharmacologic intervention, drug therapy becomes the preferred treatment to relieve the patient's debilitating symptoms. And once the patient is more comfortable, you can pursue the real cause of the patient's problems. Pharmacologic intervention is critical here because it stops the cycle of deterioration and buys time for the patient to evaluate his or her own situation and adjust to that gap in expectation reality. It also allows the physician to build the patient's trust and confidence so that he's receptive to counseling or even psychiatric referral on occasion.
Please refer to Figure 1 on page 4 of the accompanying booklet. Since the medical definitions of stress have formally been expressed in terms of a laboratory response, please consider the working definition of stress for this program.
Dr. Cooper, if the consequences of stress come about because of the way we live, does that tell us anything about how physicians and others should try to deal with those consequences?
Certainly. Professional help can take many different forms. Counseling, a referral to a psychiatrist, and very often, as we've just said, drug therapy.
Well, drug therapy, pills. Pills are a matter of very considerable public concern today, are they not?
You bet, concern and confusion, particularly in regard to tranquilizers. Now, that's why we plan to look at the role of the benzodiazepines, a particular group of tranquilizers, and particularly in that group, Valium, as the most frequently prescribed drug. It and other agents in the anti-anxiety or sedative hypnotic classes are used repeatedly in the management of stress-related problems. It's a difficult time for both physicians and patients as far as feeling confident about the choice of appropriate therapy. On the one hand, we have the scientific and clinical research and the literature over the many years have definitely established the safety and reliability of Valium and some of the other benzodiazepines. On the other hand, a number of reports in a variety of media recently have challenged the use of these drugs.
Well, if there is this confusion, Dr. Cooper, how do you plan to end it?
Well, the editorial board has set out 4 objectives in order to provide accurate, up-to-date information on stress and its treatment. And just let me reiterate those 4 objectives. First, we want to help people identify stress as a major factor in illness. Second, we'd like to identify the non-pharmacologic approaches that are available and effective, that is, non-drug therapy. Third, we'd like to identify the pharmacologic approaches, such as Valium and other benzodiazepines, that are available, appropriate, and effective. And finally, to characterize the proper use of these pharmacologic agents and to develop principles that will avoid their misuse.
That's simply stated, Dr. Cooper, but an extremely ambitious plan, is it not?
Perhaps, but the editorial board is acting upon a concern that most physicians already hold. How to help people avoid the misuse of drugs without sacrificing their appropriate and constructive use. Now, as a matter of fact, the abuse of these drugs is very, very small when you consider the number of people who take them. We want to bring together the best information available for participating physicians on appropriate therapy for patients suffering from stress.
Is it possible to say how many people are affected by stress?
Oh, not precisely, but experts estimate that more than 50% of all patient visits to physicians are directly attributable to stress. Remember, though, that management of stress is a part of the total care of every patient, whether the patient's physical symptoms are caused by stress or by infection, trauma, degenerative disease, or abnormal metabolism.
Do we know how many people are treated for stress with drugs?
Well, epidemiologic studies several years ago indicated that approximately 15% of adults in the United States had been treated with an anti-anxiety drug within 1 year. Of that group, about 6% had used an anti-anxiety drug for 6 months or more, and had also, interestingly enough, used such a drug at least once in the previous year. Now, the use of a tranquilizer for more than 1 month indicates a disability that goes beyond the superficial stresses and strains of life.
Please refer to Figure 2, the graph on page 5, which compares the number of patients treated with psychotherapeutic drugs for short-term relief of stress with those treated for more than a month or in the previous year.
How does use of tranquilizers in the United States compare to use in other countries?
About middle range. We're not unique. In an epidemiologic study in Western Europe, the proportion of the population that used an anti-anxiety or sedative drug at least once during the prior year ranged from 17% in Belgium and France 16% in Sweden, 15% in Denmark, 14% in Germany and the United Kingdom, 13% in the Netherlands, 11% in Italy, and 10% in Spain. At the lower end of the scale, you have to make some allowances for differences in accessibility to medical care.
Please refer to Figure 3, the graph on page 5, comparing psychotherapeutic drug use among adults in the United States and Western Europe.
I've heard it said that women use tranquilizers more than men do.
Yes, that's true. In an epidemiologic study of the U.S. population, 8% of the men and 20% of the women had used a minor tranquilizer or daytime sedative at least once during the past year.
How does that compare with the use of tranquilizers among women in other parts of the world?
Oh, in almost every country, the use of anti-anxiety or sedative drugs appears to be twice as high among women as among men.
Please refer to Figure 4 on page 6, comparing use of anti-anxiety sedative drugs among women to use among men in the United States and in Western Europe.
Dr. Cooper, can you explain the higher use of tranquilizers among women?
No, I can't. The emerging role of women has been suggested as an explanation, but I think it's simplistic to accept one factor to explain these data. I feel there must be a multifactorial base. For one thing, women go to the doctor more often than men.
You're saying that men suffer in silence.
Perhaps. You may be like me. It would be hard for me to complain about something that I would equate with being non-masculine.
Is that the reason, then, that men take fewer tranquilizers to protect their own version of their virility?
Well, men may deal with their particular problems differently, but not necessarily more successfully. Men may be using alcohol rather than a tranquilizer as a chemical coper, so to speak. Various studies consistently show that far more men than women use alcohol. Driving too fast is another unsuccessful way that some people try to deal with stress.
Now, please turn the cassette over to hear the balance of the program. Mr. Newman continues the discussion.
Maybe there's another reason, Dr. Cooper, because recently some women charge that male physicians are insensitive to women and so subject them to the overuse of drugs.
Yes, I've been reading about this. They seem to feel that doctors fluffed them off with tranquilizers such as Valium, which then backfired and caused psychological dependence. And it's true that some doctors write prescriptions inappropriately for these drugs as well as for others. This is the group that takes advantage of a lot of things, unfortunately, but it's estimated to represent about 2% of all physicians prescribing. But the concept that doctors give tranquilizers to make patients feel good and to get them out of their office is much exaggerated. We do need to examine the data and look behind the simple statistic that twice as many women use tranquilizers. We need to find out if women have more pressures. Is female blood chemistry different from male? Now, we have some excellent data, and we need more. But the wrong thing to do at this point would be to suggest a simplistic answer for these differences.
Have any studies broken apart the general use figures for men and women?
Yes, a survey of the general population of prevalence of psychotherapeutic drug use, that's all types and classes, not just tranquilizers, revealed that nearly a third of adult Americans use some type of psychotherapeutic drug at least once during the year. That's for both prescription and over-the-counter drugs. Women tend to use these drugs at a younger age than men.
Please refer to Figure 5, the graph on page 6, comparing prevalence of psychotherapeutic drug use in the United States by sex and age.
When you look at the use of tranquilizers according to sex and age, you find that the prevalence of both men and women who take a tranquilizer at least once a year increases with age.
Please refer to Figure 6 on page 7, which presents the prevalence of minor tranquilizer use in the United States by sex and age.
You spoke earlier about the theory that perhaps the emerging role of women had something to do with their greater use of tranquilizers. Are there any data on the changing role of women in relation to the use of tranquilizers?
Not specifically, but we do have data on the use of tranquilizers among women according to employment status, social position, and educational level. Interesting observation, there is greater use among full-time housewives who are in the top and lowest quartiles of social position, and among full-time housewives who have had some college training.
Please refer to Figure 7, the graph on page 7 that compares use of tranquilizers among women according to employment status, social position, and educational level.
What about abuse of these drugs among women?
Here's where the data become fascinating, because they knock out any possible stereotype of the pill-popping, affluent matron. Now, the women who use minor tranquilizers daily for 2 consecutive months or more are the poorest women and the most poorly educated. Remember the definition of the gap between expectations and the reality of life that we discussed earlier.
I do, yes.
Again, it's simplistic to suggest that these factors provide the whole answer, but this is information that may be surprising to many people.
Please refer to Figure 8, the graph on page 8 that demonstrates high-level use of tranquilizers among women, comparing employment status, social position, and educational level.
Dr. Cooper, is there a representative case history that would show what stress does?
Yes. Let me point out the case of Jane T., who came to one of our outpatient clinics. She presented with complaints of feeling weak and faint. She came in at this particular time because she was having palpitations. Miss T was an intelligent young woman, and she had read up on her symptoms. And so she asked, do you think I have low blood sugar? Or do you think I have a cardiac condition? Maybe I'm anemic. When we pursued the history, it soon became clear that Miss T was having interpersonal problems at work, and that she had very few satisfactions in her personal life.
What did you do for her?
Well, we carried out a careful, complete medical history and physical examination, which included an electrocardiogram and blood count. The first step was to reassure her that she did not have a serious organic illness underlying her symptoms. Now, Miss T was very concerned that her physical problems would interfere with her work, which was very important to her. She was afraid and needed reassurance that we weren't writing her off as a so-called mental case.
How did you help her?
Well, we spent some time explaining her symptoms to her. She was afraid, for example, she would faint while she was standing in the cafeteria line. She became afraid to drive her car, afraid to go into a store. Her fears about fainting and her inability to cope with her life situation were feeding upon themselves.
Did she take any pills?
Yes, she did. This lady was helped by a benzodiazepine, in this case Valium.
How long did she take it?
For several weeks, on an as-needed basis, until counseling was well established. Within 6 weeks, she was free of symptoms, and then free of the need for any drugs.
So the drug therapy bought time?
Yes, in this particular case, I think it let us ease into a management program that allowed the patient to continue working and functioning without having to withdraw from her everyday life.
Could you have helped her, Dr. Cooper, without drugs?
Yes, probably, if both the patient and a member of our staff had the time to sit down and talk for several hours every day. But the fact was that she didn't have that time, and the drug was a help as we worked through her more critical problems.
Now, what happens if such a patient is untreated?
If the patient doesn't get help or is unsuccessfully treated, which also may happen with or without drugs, he or she may become dysfunctional, unable to work or carry on even household functions. Now, home relations may become strained, and other family members may then suffer also. All of this occurs in a self-perpetuating, worsening cycle. Now, some people withdraw and stay in the house, for example. There are all kinds of consequences of not treating stress or for treating it unsuccessfully. A person may turn to alcohol or overeating. In fact, the greatest problem in managing stress is that you may fail to give the right kind of relief at the right time. If you do, will you cause the patient to seek inappropriate relief?
Please see Figure 9 on page 8 for a list of theoretical substitutions for drug therapy based on physician interviews.
All right, then. How do you avoid inappropriate treatment?
Take into account a total management scheme. If a doctor treated a patient complaining of palpitations with a cardiac drug before knowing for certain what he was dealing with, that would be inappropriate treatment. In the same way, it's wrong to treat with a tranquilizer before being certain you're dealing with a stress or anxiety reaction. You also have to know the appropriate agent, the appropriate route, dose, and time of day for administration. In other words, it is inappropriate to give any drug or treatment without knowing indications, the pharmacology of the agent, and any precautions and contraindications.
Now, would you please contrast the benefits and the risks of prescribing tranquilizers?
Yes, on the benefit side, you can introduce into a management program a specific tool that will help relieve complaints and that restores the ability of patients to function. And that's a real benefit. The risk is that of an idiosyncratic or toxic reaction, or if the patient is a pregnant woman, you may introduce a hazard to the fetus. As is true with all drugs, it's essential to carefully evaluate the patient before prescribing a drug. The most significant risk, however, is the possibility of drug interaction, particularly if the patient is using another way of coping, for example, using alcohol. Now that will amplify the effect of the tranquilizer.
Do the risks outweigh the benefits?
Definitely not, in my opinion. The benefit usually greatly exceeds the risk. Even though millions of benzodiazepine tablets and capsules, such as Valium, have been prescribed and millions of patients over the years have taken these drugs, there is a very small percentage of adverse effects due to the agent alone when it's properly used. Now, those percentages change a bit if the patient adds alcohol. Now, current statistics show that a great percentage of emergency room visits involving abuse of a tranquilizer occur when a patient mixes in too much alcohol with the drug. Now, this is what the media should be talking about. The problem is not so much tranquilizer abuse as it is patient misuse of alcohol and other central nervous system depressants along with the tranquilizer.
So these drugs, you say, are not very dangerous in themselves?
No, not in that sense. The danger is that they lend themselves to amplification by alcohol and to abuse by self-medication or by street use.
But is that not an insidious danger? And I can't close this interview without mentioning Betty Ford, among others, and all that we've heard about the misuse and the abuse of medicines.
Well, all I know about Betty Ford's case is what I've read in the newspaper. But it seems that Mrs. Ford had to deal with true organic problems and an unusual set of circumstances in her home, both good and bad. And as she put it herself, she slipped from temporary relief to misuse with alcohol and then abuse and dependence. But dependence is not irreversible. Mrs. Ford demonstrated that fantastically. And by realizing what was happening, she was able to rid herself of a dependence. And setting an example as a public figure, she also showed that people don't have to live with an evil stigma because they've had problems with abuse of alcohol with drugs. She demonstrated that with great smoothness and elegance. This, no doubt, will be beneficial to many other people.
Dr. Cooper, did the experience of Mrs. Ford have anything to do with the timing of this educational program?
No, the program was already in the planning stage when Mrs. Ford's statements appeared in the press. Her experience wasn't the reason, obviously, to present a major educational program. But her willingness to share her experience means something to me as a person. She has performed a real service. I believe that people, both physicians and consumers, will be more receptive to the objectives of this program as a result of her action.
Well, what do you see as the greatest benefit of this program?
A common understanding of appropriate management of stress, which includes tranquilizers.
Why are you putting the program on now?
The database makes it clear that both the public and the profession need a program like this. They need to develop a better understanding of stress and its management. Second, now we know more about how these tranquilizers work, about interaction with other substances, about brain chemistry itself. There's not only more information, but also broader use of these agents because more people have greater access to treatment with new programs of insurance or third-party payment. There are cultural reasons, too. Our standard of living is changing at a very rapid pace, and therefore pressures in our culture are increasing.
Then what is the outlook, Dr. Cooper? How do you plan to bring stress and its consequences under control?
Education is the key.
Well, how do you plan to educate the public?
We've already announced this program publicly, and a number of the editorial board members have participated in interviews with the consumer press. We're going to be holding a seminar for medical writers at Cornell in the next few months. At that time, we'll present our initial assimilation of the most up-to-date information available on stress. If people are generally to understand their responsibilities in dealing with stress, then the press has to help provide the information. So members of the editorial board and our visiting faculty will speak to community groups all across the country. They will also appear on radio and television and will be interviewed by newspapers and magazines. Now, to point out the importance of both physician and consumer education programs, we have received the endorsements of some of the major voluntary health agencies around the country: the American Cancer Society, the American Heart Association, the Epilepsy Foundation of America, and the National Kidney Foundation.
Let's talk about the physician program. What are the elements there?
Well, as far as the physician program is concerned, the editorial board will try to reach 15,000 to 20,000 doctors in 26 cities through a 3-hour closed-circuit telecast. Now, the telecast will focus on diagnosing and managing stress, as well as establishing improved doctor-patient communication in this field, with emphasis on the most up-to-date information on the indications for prescribing Valium and other benzodiazepines, sedatives, and hypnotics. Other program elements will be targeted at 100,000 physicians nationwide and will include a pre- and post-program self-assessment, a series of newsletters which we're going to entitle Clinical Roundtables. Now, in these newsletters, we shall discuss various aspects of stress and stress-related disorders, and we will also provide a group of films and monographs. In addition, we will recruit a visiting faculty of more than 40 eminent experts in various medical fields and in the social sciences to help us with physician and consumer education. Now, physicians who complete the entire program will earn 36 continuing medical education credits. These are determined by the Committee for Continuing Education here at Cornell by our standard criteria.
Thank you very much, Dr. Cooper. We've been talking to Dr. Theodore Cooper, Provost for Medical Affairs and Dean of the Cornell University Medical College, and Executive Editor of a new national education program for physicians and the public for consequences of stress, the medical and social implications of prescribing tranquilizers. This is Edwin Newman in New York.
Please look at the attachment to Dr. Cooper's letter for full information on the editorial board members and the program accreditation. You will find a business reply card in the program folder. Please fill it out and mail promptly to be sure that you are registered for the entire program, the consequences of stress, the medical and social implications of prescribing tranquilizers. This education program is developed and produced by Health Learning Systems Incorporated under an educational grant from Roche Laboratories.